Welcome to the THOR Table of Knowledge podcast, where we dive deep into the groundbreaking world of trauma care, hemostasis, and oxygenation research. A special thank you to our sponsor, Velico, for their support. Velico is revolutionizing trauma care with their innovative frontline ODP spray-dried plasma system, with the goal of empowering blood centers worldwide to produce dried plasma for transfusions.
Good afternoon, THOR listeners. My name is Andre Kapp. I'm a member of the THOR Executive Committee, and I'm speaking to you today from the Solstrand Resort in Norway, where we are wrapping up THOR 2025. Today I have the great pleasure of introducing you to Dr. Neal. Mackie is a trauma surgeon and researcher at the University of Pittsburgh, and today we're going to talk about traumatic brain injury and the treatment of intracranial hemorrhage in that setting, particularly in the sort of worst case scenario of intracranial hemorrhage in the presence of antiplatelet agents. So, for our listeners, why don't we start off with a little bit of a background on TBI and intracranial hemorrhage. What's the magnitude of the problem?
Yeah, thanks for having me, Andre. And I'm really pleased to be here to talk about this topic and the evolutions in this space. TBI is a global problem. More than 70 million traumatic brain injuries documented annually across the world. In the U.S., where I practice, this is 2 to 3 million emergency department visits annually. And in particular, and a very vexing component of TBI treatment is for patients who are on antiplatelet agents. That probably represents 10 to 20% of all traumatic brain injuries, at least in the United States. And importantly, that is enriched in an older population who are more likely to be taking antiplatelet agents. And as our population ages, this is increasing in prevalence and, no foreseeable change in that trajectory.
So these are patients taking aspirin or clopidogrel or one of these drugs that, usually for coronary artery disease, secondary prevention of events in that area, definitely a major problem. So when you, as a trauma surgeon, see a TBI patient who, has evidence of intracranial hemorrhage on imaging, what are your treatment options? How do you manage that? Straight to neurosurgery, decompression, or medical options? What's the approach that you typically use?
Yeah, great question that's wide-ranging, and certainly, there are terrific guidelines, including brain injury guidelines and specific, neurosurgical focused interventions to guide our care across the spectrum. To focus for a second on those patients that are on antiplatelet agents, that's particularly challenging because, first, we're often relying simply upon a history. And in the setting of brain injury with altered mental status, oftentimes a history that the patient can't give us, right? One that's just provided by, pre-hospital personnel or medical records. So compliance is unknown. And, as you well know, better than I as a hematologist, 20% of patients that are actually taking these drugs may have some underlying resistance or mutation, right, that renders them unresponsive. So really whether the history matters or not is, from the start, actually a challenge in taking care of these patients. But what we do know from looking at the literature is that taken across like the epidemiologic studies of patients with intracranial hemorrhage on antiplatelet agents, they do worse, right? More likely to have progression, more likely to go on to require neurosurgical intervention. Those numbers are highly variable and heterogeneous, probably for the reasons that I just highlighted. But it definitely should be the signal for a clinician, to escalate care, whether that is transfer to a facility with a higher level of trauma care, or for consultation in neurosurgery. And certainly a guideline, something to be considered in accordance with guidelines about repeating imaging and short interval neurologic exams.
So the key thing, obviously, is you want to stop the bleeding, right? If you have continued bleeding, you have expansion of the hematoma and compression of brain tissue, bad, right? So what are your options for stopping the bleeding?
Yeah. So in TBI in general, I think we've learned a lot in the last 5 to 10 years. When looking at the delivery of plasma pre-hospital in the PAMPER trial, we saw a 10% reduction in mortality. We learned then, looking at the heterogeneity of treatment effect in that study, that all of those patients that benefited were actually patients with traumatic brain injury. Now, those are predominantly younger patients who also were at risk for hemorrhage and had multiple other injuries. Tranexamic acid, right? And pre-hospital delivery of tranexamic acid seems to have some earlier time to hemostasis and improvement in some variables that are important. Whether those are long-term variables or not, I think are a good debate to have. But basically, it keeps us in the same armamentarium of things we have for other trauma, right? Plasma and TXA being foremost amongst those. For the antiplatelet agents, though, it adds a big challenge because we don't really have much, right? And really, probably the only two things that we have, or at least we think we have, are DDAVP and platelet transfusion. Yeah,
so DDAVP is an interesting agent. I mean, it stimulates von Willebrand factor release, can enhance the ability of platelets, native platelets or transfused platelets, to participate in primary hemostasis. So, potentially a good drug, but limited in its ability to sustain hemostasis over time. You get tachyphylaxis and sodium retention and all this, so water retention. So, what are your thoughts on platelet transfusion for intracranial hemorrhage? Whether a patient is using antiplatelet agents or not, how effective is it?
Yeah, so when I hear people talk about platelet transfusion, specifically in traumatic brain injury on antiplatelet agents, what you commonly hear is to reverse the effect of the antiplatelet agent. And I don't know what the podcast version of an air quote is, right? But we got an air quote reversal because mechanistically that's not how this works, right? The drugs are still around. There are reversible and non-reversible P2Y12 inhibitors, but fundamentally it's very different than reversing anticoagulation, which we might do with, say, PCCs or a specific antidote or reversal agent. We don't have that yet for platelet transfusion or for antiplatelet agents. There's work in that space that is evolving, and I think that's very exciting. But right now, I think intuitively the response is, well, if the platelets are inhibited, maybe we give platelets that are not inhibited. And I understand that rationale. The problem is I don't think the data actually support that, right? So we mentioned spontaneous intracranial hemorrhage earlier. Really interesting, maybe somewhat controversial study, the patch study in non-traumatic intracranial hemorrhage actually showed an increase in mortality in patients receiving platelet transfusion as opposed to the group that did not. And certainly that study has really altered practice, I think, in the spontaneous intracranial hemorrhage patient population on antiplatelet agents. When you look within trauma, we and at least one other group have done a systematic review and meta-analysis of what is overwhelmingly poor quality data, right? Virtually all observational, but looking specifically at this question of, does platelet transfusion reduce mortality in patients who have traumatic brain injury on antiplatelet agents? And the answer is no, right? Those systematic review and meta-analyses do not suggest a benefit to platelet transfusion. We don't necessarily see the same signal to harm that we see in the spontaneous ICH population. But the idea that giving back platelets that are not inhibited is somehow a reversal agent, I think, is fundamentally flawed. And that may be because of the biology of how antiplatelet agents work. It may be because of the biology of what happens to platelets in storage at room temperature. There's a lot of unknowns, but short version, I don't think that's the answer.
Yeah, well, the patch trial is definitely a problematic trial in many ways. I think it's probably been overinterpreted, but as you point out, there's relatively little data to go on anyway, so people do latch on to these trials. Patients did get platelets very late in that trial, and so I'm not sure how much they would have helped. But you mentioned the room temperature platelet, developing essentially a storage lesion during storage, that we think, based on in vitro data, reduces its hemostatic function. So recently, there's been a lot of work done in trying to improve the storage of platelets, including refrigeration. And the data, the in vitro data and animal data, suggest that actually cold stored platelets are more hemostatically effective and are also safe. And in fact, there's been one study in cardiac surgery done in Norway, wherein 7-day room temperature platelets were compared to 7-day cold stored platelets, and they were found to be at least as effective as the room temperature platelets. And then there was another arm of 14-day cold stored platelets that was also effective. So that led to the CHIPS trial that is just concluding now, and we'll soon hear results from that in cardiac surgery. But that evaluated cold stored platelets stored out to 21 days, so it should be quite interesting. Tell us about cold stored platelets and their potential for treating TBI with intracranial hemorrhage and, in the setting of antiplatelet agent use. That's sort of the worst case possible, if you think about it, sort of the most damaging injury, the worst case for native hemostasis. Are cold stored platelets going to help us out here?
Yeah, so I'll take a step back for a second and just again highlight there's sort of this almost bipolar nature of platelets stored at room temperature in trauma. We know in hemorrhagic shock that giving higher ratios and giving them early saves lives. So I don't want to say that a room temperature platelet is all evil, right? Because we know there's a benefit in that disease entity. But we don't see that benefit in traumatic brain injury. And so we've got this opportunity to improve upon the product. And then certainly addressing the resource barrier that's created with the storage limitations for room temperature is prudent. And so, that really led to two trials looking at cold stored platelets. The CRISP hemorrhagic shock and the CRISP TBI trial, both run by the Lights Network, and a debt of gratitude to you and many others that helped with bringing that forward. I won't focus on the data in hemorrhagic shock because it's a little outside of scope of what we're talking about today, other than to say that in that trial, which was published in Annals of Surgery in 2024, cold stored platelets were feasible and safe. And what we showed in that trial was that actually storing those platelets in the emergency department resulted in them getting to the patient a lot faster. Now, that created a big limitation in actually interpreting any result, whether it's time to delivery or temperature storage, that we can and should talk about. But that was then sort of the kickstart to look at this in TBI. And so we did the CRISP TBI trial, which was a small trial, 100 patients, single center, that included adult patients who needed a platelet transfusion, all of whom turned out to be on antiplatelet agents, either aspirin, so it would be aspirin, a P2Y12 inhibitor, or dual antiplatelet use. And they were randomized in an open label fashion to cold stored platelets versus room temperature platelets. And, certainly looking at safety and feasibility, but outcomes of 6-month GOS and mortality. Some very, interesting results. So no signal for concern with safety. And I think you highlighted, the idea that cold stored platelets may be more hemostatic based on some of the fundamental biology. I think anytime we talk about something that's more hemostatic, it raises the question, is there going to be more thrombosis, right? So looking across both of both the hemorrhage and the TBI trial, no increase in AEs, no signal to thrombosis, really a pretty resounding safety signal for cold stored platelets in both disease entities. No significant changes in the 6-month Glasgow outcome scale. There was an absolute reduction in mortality in the CRISP TBI trial that favored cold stored platelets, did not rise to statistical significance. But really, Andre, I think that the most interesting data in CRISP TBI is embedded in the secondary outcomes. Now, got to put forth all the limitations, right? Not powered for that, hypothesis generating, don't want to overstate the conclusions. But what we looked at was rate of TBI progression. And we looked at that based on interpretation by radiology, and then actually using something called the Rotterdam score, which is a highly quantitative way to actually look at radiographic progression across CTs. And what we saw was that there was a reduction in that TBI progression in absolute values, pretty consistently across the board associated with cold stored platelets. And really the most striking thing that we took away from that was when you looked at the need for neurosurgical intervention, so going to the operating room for craniotomy or craniectomy, there was a statistically significant reduction in the need for neurosurgical intervention with cold stored platelets as opposed to room temperature platelets. So again, we don't want to overinterpret the results of a single pilot 100-patient study. And I think we can take home convincingly a signal for safety and feasibility. But there's really some provocative data to suggest that this idea that they're more hemostatic may pan out, and maybe we see that in TBI because very subtle differences in the amount of blood loss can have really profound clinical outcomes.
That's really interesting. So, yeah, I mean, it does support a lot of the basic biology work that's been done on this. But it sounds to me like, as we started the conversation, what are your options? How do you manage these patients? If the goal is to stop the bleeding, that's the critical thing to do. You may have something here that's, a new tool that's encouraging, we'll say, right? There's still a lot to be worked out. What's the right dose? That's a question, right? Is 1 unit of platelets enough? Is 2 better? Should you give it with TXA? I mean, all those sorts of things, like the bundle of hemostatic interventions to stop that bleed. And, if you can prevent craniectomy, that's good.
Yeah.
That's very good.
Well, and I would also point out, again, in a, open label, small study, you inevitably end up with differences between the patient groups. A couple of the interesting differences were in the cold stored arm, patients were more likely to be on dual antiplatelets. So if anything, the deck was sort of stacked against the cold stored platelets there. We allowed up to 2 units of transfusion, but about 75% of the patients in the cold stored got only 1 unit. And in the room temperature, it was actually more common for them to get 2 units. And so those cold stored results are in the setting of probably greater platelet inhibition and fewer absolute number of units that are transfused. So lots and lots of questions about, dose, about bundled care, adjuncts, whether, any of the other things that we do, like plasma or TXA, could be force multipliers, that would amplify this effect. But the other thing that I would come back to, and again, wanting to be clear on the limitations and where that then ultimately should take us, is the concept of time. Because just like I mentioned in crisp hemorrhagic shock, in crisp TBI, the cold stored platelets were stored at the point of care in a refrigerator versus the room temperature platelets that came from the blood bank. And the time to administration to the patient was dramatically different. Less than 30 minutes in the cold stored group, right? More than 2 hours, an hour and 30 minutes in the room temperature group. Now, some people will say that that's a flaw of the design, and I accept that critique. But the trial was designed to be practical and pragmatic. You throw those buzzwords around all the time, but the reality is, when you're looking at feasibility, right, you want to put the product in the place that it would be clinically utilized.
Right.
And so we put it in the emergency department. It led to earlier administration. We didn't know what the results would be. We didn't know there would be a signal to benefit. But now what we're left with is trying to uncouple the idea of, was it truly the cold storage, or was it earlier time to administration, which we know from hemorrhagic shock seems to make a difference. And so I think that's the next big question that is out there, right, is, if we don't switch to cold storage altogether, right, we probably need to do a study that actually controls for time, that randomizes from the blood bank so that the cold stored and the room temperature go in at the same time. And we really understand, is there something fundamentally different from a hemostasis standpoint for that cold stored platelet?
So on that point, all the in vitro data was done, we tested the hemostatic function of cold stored versus room temp platelets using a wide variety of different assays. There's no gold standard assay for platelet hemostatic function. They notoriously don't correlate well with clinical outcomes. In your trial, you did do some platelet function studies that could help us potentially, if there was a difference, uncouple this question of, was it time or was it function? Can you comment on that?
Yeah, so we measured on every patient that we could get samples for, which was the vast majority, point of care assays that we clinically use for detecting platelet inhibition, which included the Verify Now assay, either the aspirin response or the PRU for the P2Y12 inhibitor, and then we did TEG with platelet mapping. We've got a separate publication that looks across the study, irrespective of arm. And then we have an upcoming presentation at the AAST 2025 meeting that will focus on the individual treatment arms comparing cold versus room temperature. What I can tell you from the published data, though, is that when you look at those tests, right, what they tell you is, if there is inhibition present on admission, it suggests really what we already know, which is, if you're on an antiplatelet agent and you demonstrate platelet inhibition, you do worse, right? So looking at those clinical outcomes of, rate of TBI progression, need for neurosurgical intervention, right? Both for Verify Now and TEG with platelet mapping, they predicted that that patients did worse. But what was really interesting is that, and there were some important differences between those two assays and the specific variables that we looked at within TEG that are highlighted in the publication. But we also repeated those tests after we gave a platelet transfusion.
Okay.
And what was really interesting is, despite seeing an improvement in the platelet function on those assays after platelet transfusion, that improvement, right, the delta between admission and post-platelet transfusion, had absolutely zero correlation with any clinical outcome. And so Like any good science, I shouldn't call my own science good, right? Like any science, raises more questions than it does answers. And so I think there's probably at least two there. Right?
But was there any difference between people who got cold versus room temp, whether or not it correlated with outcomes?
Yeah. So that's what will be presented upcoming. And what I will tell you, as maybe a little bit of a spoiler, is the numbers now when we get down to this, right, 50 patients per group, are pretty low. And it's very difficult to say whether or not there's any meaningful change that comes between those two arms. And I think that's also confounded by some of the differences in the degree of platelet inhibition, with there being more patients on dual antiplatelet agents in the cold stored and the number of platelet units that are transfused.
Sure.
So, the water's muddy there, right? But I think there's two, so I don't know that we've answered that question, even though this is really the first study that looked at platelet function in a patient who received cold stored platelets after trauma,
right.
Which is part of why I think the investigation was important. But if we go back to that difference, right, there's two questions there. So one is, did the test fail to detect the impact of the resuscitation, right? Mm-hmm. So those tests, they tell you there's inhibition, they tell you there's inhibition is bad, but do they not detect our intervention? So should we not use those for monitoring and making decisions about subsequent transfusion? Or, right, is the actual act of transfusing a platelet not beneficial to the patient? You see an improvement in platelet function, but it doesn't correlate with the clinical outcome. I think the fact that we see some signal to benefit in the cold stored platelets means that there probably is an impact of that. But again, I don't want to overstate the conclusions of a small study.
I mean, I think this is what you've shown with this study is certainly no reason to not pursue further investigation, right? It's safe, it's feasible, great. We should do a bigger trial to get more definitive answers. And you've got a signal that it's probably worth doing because everything is sort of trending in the right direction. We can't make strong conclusions from this, but trending in the right direction is a good thing. So it sounds like, we shouldn't ask too much of the data in a small trial, right? Mm-hmm. But definitely rationale for a pivotal study.
Yeah, and so, it's interesting because it just presented these results and somebody got up and asked a question at the end and pushed back and said, well, look, if it's safe, if cold stored platelets are safe, and maybe there's some benefit to effect, but it improves storage duration, it improves access to platelets based on that storage, and there's no concerns about safety, why wouldn't we switch to cold stored platelets altogether? And they pushed back and said, you shouldn't do a definitive trial because we should just switch based on feasibility and practicality of implementation. And, I think that's interesting. And if we were exclusively in a vacuum of trauma, you might be able to make that argument. The issue from a transfusion medicine standpoint, right, is that the whole reason that platelets were approved for room temperature storage in the first place is when you look at recovery of transfused platelets, room temperature platelets stay around longer in circulation after transfusion. For all the reasons that you have just highlighted, that your science and others have proved, those hemostatically activated platelets in cold storage seem to get cleared faster. And so the rationale when platelets were approved for storage at room temperature was if they are to be used for prophylaxis, such as in an oncology population or in chronic thrombocytopenia, we want a platelet that's going to hang around longer, theoretically. And so the idea of, well, we're just going to change the blood bank and we're going to put all the room temperature platelets into the fridge, that presents potentially a challenge for the idea of utilizing them for prophylaxis. But I think what's really important is like, we should really revisit that idea and that data and understand the value of recoverability as a metric before we make decisions about how we are going to change platelet transfusion and platelet storage in the future.
I totally agree with you. The whole field went from refrigeration to room temperature storage without a pivotal trial. And now we're stuck with this conundrum that you just eloquently described. And we do need to do the studies. I totally agree. The enhanced safety of cold stored platelets from the bacterial growth standpoint and all that, I think is a pretty strong argument for really pursuing this and getting the answers, because we're exposing patients potentially to harm with room temperature stored platelets. Maybe we don't have to take that risk. In my clinical practice, I don't think the recoverability of platelets post-transfusion makes the slightest difference in clinical outcomes in hematology and oncology patients. But we should prove that, as you said. So let's do the trials. Well, Mackie, this has been a really interesting discussion. I think it highlights improvements in an otherwise dismal area of medicine. I mean, traumatic brain injuries, terrible outcomes, and so forth, and having a new tool that could potentially improve outcomes pending more definitive trials is really exciting. So thanks for that, and look forward to our next discussion.
It's been a pleasure. Thanks, Andre.
All right.
That's a wrap for this episode of the THOR Table of Knowledge podcast. A big thank you to our sponsor, Velico, for supporting the advancement of trauma care. Their frontline ODP spray-dried plasma system is paving the way for blood centers globally to produce potentially life-saving plasma for transfusions. Check out our website, www.thornetwork.com, for more podcasts, and join us next time as we continue to explore the cutting-edge science of trauma, hemostasis, and oxygenation. Until then, stay safe and stay informed.